So everybody, it is so great to see you here. Thank you so much for coming today. We are really excited about today's presentation, Palliative Care, Extra Support for People with Cancer. This is a collaborative effort, as always, with Kōkua Mau and Palliative Care. We are a team-based effort. So this is a presentation that comes about because of collaboration from the Quality of Life Committee with the Hawaii Cancer Coalition and Kōkua Mau, which I'll talk about in just a minute. So when we were putting together this session, the Quality of Life Committee asked for a variety of different voices to be included. They asked for a physician. First choice was Dr. Daniel Fischberg, so fortunately he could make time today. They asked for the voice of a caregiver, and Andrea Bacos is going to share her very moving story. Kleenex, if you don't have Kleenex yet, now's a good time. And then Sara-May Colón, who is going to speak as a chaplain and about spiritual issues. I have a very small role, which is to give a little bit of background information. I'm obviously not Hope Young, who was supposed to be the moderator today. She is fulfilling her civic duty and in jury duty. As we keep going, please put into the chat where you're from. I'm just going to do a brief overview of Kōkua Mau for folks that don't know. We are a statewide community benefit organization that started back in 1999. We are basically a hui, and our members come from across the state who play a variety of different roles, including the cancer world. And we have just amazing volunteers and people who are involved with our work. And that really is looking at how do we create a continuum of care, starting conversations early with advanced care planning. We want people to understand what the different treatment options are. Today, we're talking about palliative care. We also want people to know about hospice, bereavement services. So Kōkua Mau really tries to take care of a variety of different pieces of how we care well for people. And as I was putting our slide together for today's presentation, I wanted to include Kōkua Mau's vision and mission because I think it fits in so well with what we are trying to do as we seek to improve care for people with cancer. How do we support people? So our vision is that the people of Hawaii are treated with dignity, compassion, and love throughout their lives. So, and Kōkua Mau's part of that, our mission is to weave a lay of caregiving and support so that the people of Hawaii facing serious illness can live in the place of their choice with relief of pain and suffering and according to their values, beliefs, and traditions. And as I said, I included that because it's so much of what we are trying to do with the Quality of Life Committee, but also all of the work that is going on. How do we care for the whole person? How do we care for their loved ones? How do we support those who are caregiving? So I really hope people will get more involved with our work so that these conversations, open conversations about care and support like we're having today become the cultural norm. So all of you can play a role and we welcome you in our fortunately ever expanding coalition. So we know that it's lunchtime and some of you are eating, but we also want to keep you awake. And we really also want to hear from you. This is an interactive session we want to hear from you. So, first of all, as we're going along, be thinking about questions. We're going to ask people to put them into the chat rather than asking people to unmute themselves. We know how that sometimes goes. So we're going to keep everybody muted for this session, but be thinking about your questions. So the first thing we'd like you to do, put into the chat, when you hear the words palliative care, what are the first things that you think of? So don't worry if you aren't quite sure. We'd like to hear, what is it that comes to mind when you hear palliative care? Do you have any? You came to a session today, so what is it that you think of when you hear palliative care? Comfort, supportive care, holistic medicine focused on the whole person. Pain management, support for family. Excellent. Super. Palliative symptom management, still receiving active treatment. Okay, very good. So thank you. Keep putting in your ideas, improving quality of life. That is great. I am going to launch a poll because we want to hear from you. And the question is, how confident are you in explaining the differences between hospice and palliative care? So again, no wrong answer, and your answers are confidential. Okay, Daniel.
Jeannette, did you hear about the fire at the circus? It was intense.
Okay, Daniel has the best dad jokes in the world. You know, I didn't hear about that.
Jeannette, last night I dreamed I was a muffler. I woke up exhausted.
So you folks can hopefully see this. Some people, nine out of 37 people answered. They're very confident. The majority somewhat, and fortunately 5 people not confident at all and willing to admit that.
Well, thank you, Jeannette. The first thing I noticed is that you seem to have recruited an extremely astute audience. They were pretty spot on there in the chat, and I think their assessment of their confidence may be spot on too. So maybe I'll be able to go through this very quickly, but I wanted to do a quick discussion on introducing palliative care to people, and yet this audience seems to maybe have a good grasp on the subject already. I will warn you though that as Jeannette, Jeannette won't let me talk without doing the dad jokes, so I'm just gonna get it over with first. So did you hear about the guy who invented lifesavers? They say he made a mint. Which part of the body is most trustworthy? You can always count on your fingers. Last one, I promise. I'm thinking of reasons to go to Switzerland. The flag is a big plus. Okay. So, I borrowed this from my friends at Stanford. There's a word cloud about palliative care. And, you guys pretty much recreated this in the chat. All of these different elements about quality of life and comfort. I really like the word hope in there because to me, that's just, I feel this is an extremely hopeful field. And, my hope is always that, as a team, we can help to make tomorrow a better day than today, and that we'll make today better than it was yesterday. Here's the sort of official sort of elevator definition of palliative care. Palliative care is specialized medical care that treats the symptoms and stress of a serious illness, and the goal is to improve quality of life. And that's what so many of you reflected on in the chat. And then I'm borrowing this from my colleague, Steve Pantelet at UCSF. So this is the really short elevator ride when you should have just taken the stairs. The goal of palliative care is to help you live as well as you can for as long as you can. And I also really like this definition. This is the title of Ira Byock's last book. And Dr. Byock is one of the founders of the American palliative medicine movement. And he just referred to palliative care as the best care possible when you're living with a serious illness. And I really feel that sums it up the best. Unfortunately, I can't control myself. I am going to show you guys some data, but I thought more powerful than that, we might start with a story. And this is a story about a patient. I'll call him Bobby. He was cared for by one of my partners in our team here at Queens. And Bobby was 58 years old, and he had had a lung cancer operated on, but the cancer had come back. He was actually referred to see one of my partners because the pain was really pretty severe in his chest wall. And he was having a lot of difficulties with cough and shortness of breath. And all of this had made Bobby pretty depressed. And he really wasn't able to get around as much as he had before. Palliative care doc got on board and started prescribing some different pain medicines, and actually added a pain medicine called methadone, which helped even more. And with his pain under better control, Bobby's mood got better. He sort of talked about what his goals were by the third visit. And Bobby recognized, that this was a serious issue, that his cancer had recurred. He definitely wanted to take whatever treatments he could. He had a family that he definitely wanted to have a lot more time with. But at the same time, if things were not going well, he did not want to he wanted to have his life prolonged. He did not want to have his dying prolonged. So they filled out an out of hospital do not attempt resuscitation form while Bobby was proceeding with his treatment. Well, then he started an immunotherapy trial. And this was actually a few years ago. So it was when immunotherapy was a little newer for us. And he had a really robust clinical response. His breathing and his cough got so much better. All of a sudden, he could start going back to doing all the things he'd been able to do before, gardening and working around the house. And in fact, the pain got better too. So he actually didn't need any of his pain medicines anymore. And actually, it's 5 years and counting, and he has no signs of the cancer, no measurable disease. So at his last palliative care visit, they revised that provider order for life-sustaining treatment form. And with Bobby's disease in remission, he said, you know what, I want to be full support. I revoke that do not resuscitate. And he actually no longer requires routine palliative care clinic follow-up. So I highlight this case because I think, when he needed it, Bobby could really benefit from palliative care. And then he got a great treatment response, and they were able to wean down the palliative care and actually discharge him. So just sort of pointing out that the common misconception that palliative care is somehow synonymous with end-of-life care is just really incorrect. So this is the team of folks I work with here at Queens, and it's to remind me that palliative care is really done by a team. So we have doctors, nurses, social workers, a chaplain. Those are sort of the core disciplines of any or spiritual care provider. Those are the core disciplines of a palliative care team. But of course, we collaborate with all kinds of other therapists as well, psychologists, physical therapists, occupational therapists, dietitians, and so on. They're not members of the team, but they're very close allies that we're working with, along with all of the other medical specialists that we need, whether it's in medical oncology, surgical oncology, cardiology, radiation, and so on. So it's like compare and contrast. If you remember back in high school, this is what palliative care is not. It's not about giving up on a patient. It's not in place of curative or life-prolonging or disease-modifying treatment. And it's not the same as hospice or end-of-life care. And you guys clearly recognize that in the chat box. What it is evidence-based treatment with vigorous care of pain and other symptoms. And it's care that people, when they're asked, want at the same time as efforts to cure or prolong life. They may not know the word palliative care, but when you describe it for them, they say, yeah, I want that. So palliative care can be delivered in lots of different places. A lot of our time is spent in the hospital as a consultation service. We go every place in the hospital. In nursing facilities, I sort of put in here this picture of this black hole that they recently got of our galaxy, because it's not that it's unavailable, but it's certainly nationally one of the areas where it's sort of a little bit of a gap in terms of getting palliative care services in a nursing facility. But I'd say nationally and very much in Hawaii, community-based palliative care has really taken off quite a bit in the last few years. It was largely a hospital-based program, but more and more, there are all kinds of different kinds of community-based palliative care. We have office-based palliative care embedded in the cancer center here at Queens, but there are many home-based palliative care programs that will come out to your home. And of course, one of the pandemic silver linings is that people have just adopted telehealth so much more. It's so much more convenient for people and safer to be able to get the care by telehealth. Lots of different articles. I'm not going to bore you with too many of them, just a select handful. These are some of my favorite articles and some of my favorite people, but evidence that shows that palliative care does reduce distressing symptoms like pain and shortness of breath, the way it did for Bobby, improve quality of life. It's associated with increased family satisfaction, and there's even some interesting data on possibly being associated with prolonged survival. This is, if there's one seminal study in palliative medicine, this is it. This was from the New England Journal of Medicine back in 2010, and it was one of the first randomized controlled trials, which is kind of the highest kind of trial we can have in medicine, where 151 patients with a brand new stage 4 lung cancer were randomized to either get the best possible care in the nation there at Mass General, or automatically also get early palliative care at the same time, not waiting until somebody had progressed or had an uncontrolled symptom or a problem where the family was distressed. And what they found, just in the green box here, there are 3 different scales that they were measuring quality of life. These are all quality of life scales, and they all had improved quality of life, and the p-value there is a statistical measure that shows that statistically the quality of life was better for the people that got the early palliative care rather than the standard care. And this is looking at some symptoms of depression and anxiety. These are 3 different scales that measure depression and anxiety, and the early palliative care had less symptoms of depression and anxiety, and these were all statistically significant. And then this is something that's called a Kaplan-Meier curve, and this is the way doctors will look at survival when people get a treatment. And so at the beginning, on the y-axis, you see 100% of people are alive, and as time moves along, some people pass away. And then you're looking at time on the x-axis, and what you can see is that the people that were randomized to the early palliative care trial actually had like a 3-month longer survival in this, and it really surprised people. And this has actually been shown in some other studies. There's some studies that haven't shown a difference, but importantly, there's never been a study that's shown palliative care been associated with a shorter survival. It's always neutral or longer survival. We don't think that the evidence is robust enough to say palliative care prolongs your life, but I just certainly want to dispel any notion that palliative care is associated with a shorter survival. So the number of palliative care programs is growing rapidly. This is recent data from the Center to Advance Palliative Care. And you can see the vast majority of US hospitals of at least 50 beds or more do have a palliative care program. And I've been here in Hawaii now 18 years, and I definitely have seen that growth here. The number of palliative care programs throughout the state has really increased quite a bit. And as I mentioned earlier, now these wonderful community-based palliative care programs. I want to actually highlight one local study that a colleague of mine, Rita Bell Fernandez, who's in the Department of Geriatric Medicine with me at John A. Burns School of Medicine. She did a project with the Ohana Health Plan, and they did a program of one of these community-based palliative care programs. Sometimes they're called supportive care, concurrent care, palliative care. This was a small study, just about 20 patients. Most of them actually had a heart problem, not cancer, and most of them were Native Hawaiian or Pacific Islander. But Dr. Fernandez and her colleagues were able to show statistically significant improvements in pain, anxiety, and shortness of breath. And those are really important symptoms when you're talking about a cardiac diagnosis. Patients did a lot more advanced care planning. The number of ER visits was dramatically reduced. The number of days or admissions to the hospital were dramatically reduced. And then overall, the program ended up saving money. So lots of measures of better quality for lower cost. So we call that value. So Ohana Health, I understand, is actually now going to start to offer this as a benefit because of the good results here. I just want to make a point that timing about palliative care really is something that we think kind of matters. And this was a study of a retrospective analysis of nearly 400 cancer patients, and I think this was at MD Anderson, and it was early versus late palliative care. And the people that got early palliative care also, again, just like the last study, had fewer ER visits and fewer hospitalizations, and they were also much less likely to pass away in the hospital. And study after study shows that in general, people really would like to avoid being in the hospital at the end of their life. I want to shift and talk a little bit about, talk a little more about timing. And these are 2 diagrams just to sort of try to show the idea that the old-fashioned model is that we wouldn't do really any palliative care. At the time of diagnosis, everything would be focused exclusively on disease-directed care, trying to control the disease, cure the disease, prolong life, but with not really a lot of attention to symptoms, emotional support, family support, communication, and so on. Until perhaps the very end, there's a lot of symptoms, there's a lot of distress, so palliative care gets wedged in there at the end, and partly as perhaps a bridge towards hospice care. And what we think is a much more sort of enlightened approach is at the time of diagnosis, we start some palliative care efforts right away, yes, the majority of treatments are focused on controlling the disease, and what we call primary palliative care. So the oncologist, the nephrologist, the cardiologist, whoever the primary care doctor is attending to symptoms, is attending to emotional needs, family support, and so on. As disease progresses and over time, yes, maybe there's a need for specialty level palliative care services, and that comes to occupy perhaps the bulk. And then when the disease directed care has been maximized, then is perhaps an earlier transition to hospice care. And this is a cartoon that it came out in an article about a month ago, and the authors, this was in the Journal of American Medical Association Oncology, talk about palliative care. They use a metaphor of palliative care as an umbrella. And in the first one, there's a late palliative care referral. The couple is working with their oncologist, and then the storm comes, and the couple gets a little bit drenched, and then the oncologist comes after them to offer them the support of the umbrella, offering some help once the storm clouds have hit. Whereas in the lower panels, the umbrella is being offered. You don't need it now, but this is just in case. And then it sort of provides some protection when the storm does come. And the authors make the point, keep in mind that palliative care is the umbrella. It's not the rain. Because sometimes, people have this confusion with palliative care. They think it's about comfort care only, or they think it's end of life care. And so they say, well, I just got diagnosed. I'm here fighting for my life. Why would I want a palliative care referral at this time? They need to understand that the palliative care is the umbrella. It's not the rain. And yet predicting the rain can be difficult, but having an umbrella is not going to make it rain. I gave this to one of my oncology colleagues, this article, and he thought it was a really helpful way for him to explain why he would be referring for someone for what we call supportive oncology at the time of diagnosis. When they're not having any symptoms, their distress is just about the news, and they're just getting ready to start their treatment. And why do I need to meet these new people? Andrea can talk a little bit about that, I think. But he said he thought the umbrella could really help explain that. So this is a quote that I come to really like from my mentor and the most famous and smartest palliative care doctor on the planet, Diane Meyer. And she makes the point that palliative care is not about prognosis, it's about need. And it's about relief of suffering, and it's everybody's job. But I really like that first part. It's about prognosis. It's not about prognosis, it's about need. So if there's an unmet need, then maybe it's a good option for palliative care. So just to summarize, palliative care focuses on relief of suffering, relief of pain, promoting best possible quality of life. Again, those are all things that many of you identified in the chat. It can be considered for any serious illness. It can be used at any time in the course of the illness. We do think that earlier is generally better. It's person-centered, it's family inclusive. It can be combined with curative treatments, right? It's not instead of curative or disease-modifying treatments. And yes, some studies have shown a survival advantage. It's available in most hospitals, and there's increasing community availability, particularly here in Hawaii. And I think those are my formal comments. Jeannette, I'll turn things back over to you.
Well, thank you very much. Excellent presentation. So people, for folks here, what we're trying to do is think of collecting your questions. Barbara had asked a question of where you're going to find palliative care, and we have I'll do a short presentation about that in just in a few minutes. But the next presenter is, we're going to show a short video from Andrea Bacos, who's telling her story.
Aloha, Andrea. Thank you for joining us today. We really appreciate you sharing your experience with palliative care. Tell us how you came to learn about palliative care. What's your story?
Okay. I got to learn of palliative care because my husband Lance was diagnosed with stage 4 liver, lung, brain cancer, and eventually adrenal gland cancer in January 1st, 2018 at Queen's Hospital. We flew in from Maui. We're actually from Maui, and we went to the ER at Queens because something was wrong with my husband, and Maui doctors couldn't diagnose him, kept saying it was a flu. We went to the ER, and within 2 hours, Lance was diagnosed with, of course, stage 4 liver, lung, brain, adrenal cancer that was not curable, but they're going to possibly treat, and sent us up to 7F. The oncology floor at Queens Hospital, where a team of doctors were assembled within 2-3 days, and one of that team was our famous pain and palate doctor, Dr. Fischberg. And that's how we got first introduced to what pain and palate was.
When you first heard about pain and palliative care, what was your first impression?
Our first impression was, this is the pill doctor. This is the pill doctor that only going to give us pain meds. That's it. Nothing else. You're going to say, okay, how much narcotics do you want? And that's it. That was when I first heard that word. And then when Dr. Fischberg walked into the room and told us what pain and palate was, I was just like, that is not what I thought it was at all. Pain and palate is huge to anybody who's on any journey, not just cancer. To me, any journey. If you have a heart problem, if you have any battling, any type of illness that you're battling, pain and palate should be in your guys' care, in each patient care treatment, if you ask me, because pain and palate plays a huge part, huge, to where it is emotional. He played a super emotional support system for us, not just with my husband, but with me and the kids. I have 2 kids. Along with pain, understanding my husband's body, getting us to know what to expect, what we might going to expect, and just introducing all the support systems that's out there, from treatments to what we can get to hospice, to all the little, I just call them, just what I told my husband, it's like a big octopus, and all their legs, that's Dr. Fischberg. Because he has a lot of different legs. And so, because my husband, at first he's digesting, he had cancer, got diagnosed with cancer, and he only got given 6 months to live. He only heard that. Everything else was irrelevant to him. So I was his ears, I was his eyes for my husband, and understanding, okay, who are you and what are you doing? What is your job? Kind of a deal.
So with all of those different diagnoses going on, did you have a bunch of doctors working together, or were they each kind of doing their own thing?
No, this is the amazing part of Queens. And I work for Pacific Cancer Foundation here in Maui. Anyways, the amazing part of Queens is one whole team. It was amazing to me that cancer doctor came in, right? Right after that, the pulmonologist came in, lung doctor. Right after that, his gastroenterologist came in, and they all knew what the other one was doing. They're like, oh, Dr. Akoba just came in and he said this, and we're going to piggyback with him. And I just was like, wait, what? Like, how do you know that? So each doctor was tag teaming, like, tag, you're out, you're in, you're out. And then Dr. Fischberg comes in and he's like, okay, you're, Dr. Cool, infectious disease, Dr. Blah, 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 blah. All these 4 or 5 doctors before him. He knew what each game plan was of each of individual, which to me was breathtaking and relief that, no, this doctor just told us that. Why are you telling us different? They were all on the same page.
That sounds amazing. I mean, that whole approach as a team, I'm sure it made such a difference to the care that you were receiving.
Well, it made a huge difference. Yeah.
How do you think the palliative care aspect really supported your husband and even you? How did it support you during this journey?
It supported us a bunch of ways, not just alleviating my husband with whatever pain he was dealing, but emotional. My husband could actually literally, he's a very prideful man. Lance is a very prideful man, and I get him. Typical local, I get him. I got this. I don't need to tell what I'm feeling inside. And pain and palate actually got him to open up and actually tell his down, deep soul bearing emotions or feelings, about whatever to call me, my husband's growing up days, he bought out. And as a wife of 28 years, he would bring some out, but it was too hurtful for my husband to talk about. Well, here comes Dr. Fischberg. And my husband just poured it all out to where it put that at ease, at rest. So my husband could battle. So the pain and palate was emotional, definitely support of me and the kids, because now I gotta support everybody now. I gotta be the foundation to our family. It was my husband. Now hear me, gotta be the foundation, but his caregiver, but to be a mom, I gotta be a wife, I gotta be the advocate for my husband. I was all of this. And Dr. Fischberg was actually, to me, the one that stood beside me and said, we're gonna fight this journey together. Don't worry about it. If you don't understand, you ask, and you ask me, and I will get you an easier answer. Because a lot of times doctors would say certain stuff and I'll be like, okay, just let him go, right? Let it go and just try to figure out what he's saying. And Dr. Fisher will come. He said, you understood what Dr. Aoki said about Lance's stomach? And actually, I didn't. I worked medical field for 10 years. I know. I'm in the medical field, but I didn't. And so what I said, yeah. He goes, oh, that don't look like a, yeah. It looks like a, yeah, but not a yes. And I said, yeah. He goes, let me break it down to you in English. Great. And that's what he did. He would break down procedures we were soon getting, like, they did, I forget what it's called, but they glued my husband's lung to his ribs. And I didn't know what they were talking all doctor talk. And I was like, and Dr. Fisher was like, basically, they're going to stick chemo into his stomach, and it's going to gravitate and it's going to lynch onto your husband's lung, and it's going to pull it towards his ribs. And his lung won't open like every normal person, but it's going to open a little. But it had to be because chemo fluids was sitting behind my husband's lung. Dr. Fischberg broke that down even more for us, because okay, now my husband can go endure this procedure, this invasive procedure, but understanding it and being comfortable with it, versus, okay, I gotta go do something that I don't even understand, but I gotta go do them because I'm gonna die. Dr. Fischberg broke it even plain man's terms. This is what's gonna happen. So, and that said a lot.
I can't imagine how helpful that would have been, to just be able to understand what was going on. And it sounds like Dr. Fischberg really bridged the gaps between you and your husband's other providers.
Yeah,
So
no, Dr. Fisher definitely was my husband's bridge. And actually, my husband, numerous times when we hung up on him, my husband was like, oh, I would judge that man too early when we first met him, because we were angry, right? Like, we were angry, we were mad, we were sad, we were scared, all of this. And here comes happy Dr. Fischberg. Hi, guys. And we're like, not now. But, my husband, towards in the middle of his journey, he's like one bridge. He's bridging everything for us so we can actually travel the bridge safely and comfortably and with confidence. You're battling cancer, you're going into all this treatment, we're putting you on IV chemo, we're putting you on this radiation, and okay, but to actually cross that bridge smoothly and with confidence, so you can go in and come out with confidence. Dr. Fischberg gave my husband confidence. My husband had confidence. He was a very confident man. But Dr. Fischberg, a pain and palate, would give him confidence. Like, Lance, you're going to go in there. This is what you're going to expect. And he expected the exact thing that he got. And came out, was like, okay, Mama, that's what Dr. Fischberg said. And it did happen. So it played a huge role in bridging procedures for my husband, definitely. And me, because I knew exactly what my husband was going to endure. And knowing, okay, he's going to be okay. He's going to lie down over there for 15 minutes. He's going to swallow this. He's going to flip him like a huli pig. That, whatever it was. That's what Fischberg said. They're going to flip him like a pig, like a huli pig, for the chemo to gravitate. I'm like, oh, okay. He said, think of it like a huli pig or a huli chicken on the thing. I'm like, okay, I can see that. But yeah, that was going into procedures and just overall these things, especially things you not know of, it was super important. And we could understand that.
wow. So I know Lance was the patient, but how did it support you as his wife? Palliative care.
Lord, oh Lord. Okay, palliative care supported me I'm not gonna try to break down because I already broke down. It supported me emotionally, a lot emotionally, because I never left my husband's side for 4 years. When he got diagnosed, I'm the one that took him to Queens and never left. I stopped working, and Pain and Palette would come in, and they would, like, tell me all the services that they gonna provide by my husband, but they also would say, Mrs. Bacchus, do you need anything? Do you want to talk to somebody? Or they would actually talk to me in the room. They were like, how you doing? And you don't really recognize, but you're actually pouring out your heart to the stranger because you're scared. Like, I was scared. I was scared. I knew my husband was a very sick man, and I didn't know how to handle it. And I knew I had babies at home that, well, young teenagers, adults, that we had to tell, daddy gonna die. How do you tell your kids that your dad gonna die? Like, this is how much time we have. So emotionally, they supported me huge by talking me through things, encouraging me, a lot of encouragement, like, you're not alone. Because I felt like I was just alone. Like, I gotta hold up my husband, I gotta hold up my kids, I gotta hold up my household, I gotta figure out this financially if I want to stay in the hospital with him and not work. All of that. Pain and Palette was like, let's tap you into some programs that can help you guys travel. Maybe we can get you guys home to the kids and bring you guys back. Let's tap you into a navigator that can literally hold your hand throughout your journey, and whatever you need, she will be there, along with Dr. Pain and Palette right on the side. So they were I called them my hand holders. They held my hand, and they continue to hold my hand now, even till today, this present day. My husband's been gone for us. He died December 30th, 2021. And Pain and Palette and navigation continue to hold my hand through this journey. Even though my husband's journey is done, mine and the kids' journey aren't done. And so they continue to hold our hand.
That's amazing. Would you recommend palliative care to your friends or your loved ones if they were facing?
I talk about palliative care all the time. I have had family members here in Maui battling cancer, same time with Lance. And the first thing I brought up to my aunts and her caregivers, which is my aunties, because auntie had pain and palate, call the pain and palate care, because they pain and palate doctors, because she was in so much pain, and she was only battling cancer for 6 months. And they was like, what is that? I was like, don't you guys have and of course we're blessed to go to Queens, and Queens is the best of the best, Honolulu is the best of the best, but they're battling here in Maui, and there is a pain and palate doctor here in Maui, but Maui is just to try to figure it out, which is great. But I talk about pain and palate. It's not just for pain meds, guys. They do everything from emotional support for the patient, to families, to wives, to kids, to just a family foundation, along with supportive care, to where they can recommend, why don't you do, everybody knows hospice, right? And they hear the word hospice, it's like, that's like the end of the road, right? You hear the word hospice, it's like, okay, that's done, we're done. But I tell everybody that pain and palate, depending on your insurance and all that stuff, but they also can still help with the foundation that you're actually on. Your foundation, my thing, and I told my auntie them this, is our foundation is cracked, it's shift, but it's not broken. And with the help of pain and palate and all your other doctors, but pain and palate is like I told them, he's like they like an octopus with plenty different legs all going at the same time, but it's so supportive. So I highly recommend pain and palate all the time. That's the first thing out of mind. Do you have a pain and palate doctor?
Sounds like it was very important to the journey that you're having.
Oh yeah.
I really appreciate you sharing your story with us, Andrea. Do you have a picture of Lance? I'd love to see what he looks like.
I do. This is my husband. Can you guys see him? Was there a glare?
There's a little bit of a glare. Maybe you could tilt the picture a little bit.
Yeah. There.
There you go.
That's my husband, Lance. Yeah. There's him. Yay.
And I see behind you, you have all kinds of pictures and everything, so that he's still with you.
Oh yeah. Yeah. He's around us. He's completely around me. He's right here with me in this little forever keepsake thing. But Lance will always be with me no matter what. 28 years, we still counting.
Well, again, I really appreciate the time you're sharing your story with us and how big of a proponent you are for palliative care and what it can really do to help support families and individuals who are facing a serious illness. Is there anything else you want to share with our audience?
Just keep going. You know, those battling any type of disease, doesn't have to be cancer. It can be heart failure, whatever, but just try to stay positive on your journey. Work with all your doctors. You know, doctors aren't really a bad thing all the time. And if you can get a pain and palate care representative in your journey, definitely, because they play huge roles, and they will play huge roles with your entire family, not just the patient, everyone involved. So yeah.
Thank you so much for sharing. And again, for you folks in the audience, if you have questions about palliative care, feel free to take a look at our website. It's kokuamau.org. We have so much more information and resources for you to learn more about palliative care and what it can offer to you and your loved ones who may be facing serious illness. Thank you again for sharing your story with us.
Thank you.
Wow, thank you, Andrea. That was really wonderful. I definitely needed a moment to compose myself there. Very, as you see in the chat, Andrea, people really appreciated that your honest sharing. Really wonderful. So sorry to do this to you, Sara-May, but we're now going to shift over to you to share a little bit about your work and the crucial role of spiritual care in palliative care. So please take it away.
Awesome. Thank you so much for allowing me to be part of this. And Andrea, that's such a powerful story. And I think you're living out the legacy and sharing love and insight to something that maybe most people don't know how to talk about. And because of your narrative with Lance, I think there's a lot of life that is going to be given to people in a healthy journey. And I just so appreciate your sharing. I'm Sara-May Colón. I'm the Director of Mission and Spiritual Care at Castle, Adventist Health Castle in Kailua. And I am a chaplain. And I think often when people hear a chaplain, they either have no idea who I am, or they come up with this theory that I'm in there just to pray, bless them, sprinkle something on them, and get out of the room. But I just want to say, when I explain what I do to people, I normally say I'm here for religious and spiritual support, of course. So any way we can support you in those areas, we are here for it. But we're also here if you need a friend in the hospital, or just want to talk story, or just an extra layer of support on your journey. And often people, like I said, think mostly in the religious realm, but I think debunking that a little bit, chaplains are trained to be with you in whatever you believe in. You know, most of us can agree that a tree is a tree. And if we want to talk about nature, let's talk about nature, or the things that fill us up or bring joy and light into the world, or maybe the things that we just don't understand. Maybe it's something beyond ourselves, or a scary conversation, or maybe some bad news that came in and shook you to your core. And we're just kind of there to journey alongside of that and hear your story, and to advocate for you, and to support you and your family, and also the associates and staff at the hospital as well. So we're kind of that auxiliary person that's there as an added layer of support when possible. And I also wanted to share what the role of a chaplain is in palliative care. As was mentioned previously, there's a pretty wide variety of teams that can be part of palliative care. There's almost always that doctor presence that kind of knows a little bit more than someone like me, but there's also the social worker, the case manager, all these other layers. And often there's a chaplain thrown in there as well, because especially when you're journeying and going through these tough parts, there's a lot that comes up. And like you were saying, Andrea, in the video you were talking about, there was a lot of stuff that came up in these conversations that maybe would have never come up before. and maybe they wouldn't have been talked about with anyone else. But when you're handed weird information or things that are startling, suddenly all this information comes to the forefront, or all these memories or concerns, or do I have enough time to even deal with these things? And I think the beauty of palliative care is it sets an opportunity for you to kind of process all of the layers of it, be present in those moments, and have people rallying around you as a team to help you journey healthily and well. One of the things that I say at the hospital all the time is we try our best to heal people, and we try to do it so they live very long lives. And sometimes we can't heal them the best that we wish we could, but we can always bring hope to people. And so I think that's what palliative care is we bring hope into those broken moments, and we help them journey really healthily and well the best they can. And that way, when they get to a point where they're tired, we're able to celebrate with them in the most healthy, beautiful way, but never is it one where it stops a conversation. And so that's kind of my favorite part of being a chaplain, is I get to journey alongside people, hear their stories, advocate for them, cheer for them, process whatever wants to be processed, also support the family. And then if there's those religious undertows, I'm there for that too. But whatever it may be, that's kind of the role I love to play in that. And I'm always super honored to be part of that process with incredible doctors and nurses and techs and social workers. And so that's a little bit about what chaplains do in the palliative care role.
Well, thank you very much, Sara-May. So I hope folks are thinking about what kind of questions they have for any of our speakers. A couple of questions have come into me. So heads up, Daniel, someone asked about the difference with hospice and palliative care. So I'll come back to you. But what I wanted to do was share two slides. One is where to find palliative care. And then also I'm going to share a little bit about what's happening right now with palliative care in Hawaii. And then, so please be taking this time thinking about questions for our speakers. People have, and share those in the chat. So there was already one question of where do we find palliative care? And hopefully people are now really interested, whether for yourself or a loved one or, somebody that you're caring for, where can you find palliative care? So there is a website that's down at the bottom, and I can also share it in the chat, but it's, if you put where to find palliative care in Hawaii on the Kōkua Mau website, it comes up. So Dr. Fischberg mentioned this before. We have inpatient palliative care, so inside of a hospital. So that's going to be at Queens, at Kaiser, in the Hawaii Pacific Health world. So Straub, Kapiolani, Wilcox, Palimomi, Castle, where Sara-May works, and also at Maui Memorial. So there's that inpatient palliative care, and then outpatient, there's actually two oncology palliative care clinics. One is at Queens, and then, well, the other two, Straub and Palimomi also have an oncology clinic, and then Kapiolani has a pediatric. So those are folks who are outpatient who can get palliative care. And then the big question, and something we're really working on here in Hawaii, and I'll be honest, we still have, this is where we need you to help us be advocates, is that we have some health plans that are able to offer good palliative care in the home. And that is HMSA has supportive care. UHA has a concurrent care benefit. You'll notice the names are a little bit different. The VA, I wrote down concurrent care, but actually the VA has lots of ways of helping to care for people. And if you missed the last two Kōkua Mau webinars, they're up on our website about how do our people who are veterans who qualify for VA benefits, what kind of care and support is available through them. Check that out. If you're lucky enough to live in Hilo, Hawaii Care Choices has kupu care, which is also another type of palliative care, which has a variety of different services. I don't want to say it in the wrong way, but they really are leading the state in what's available in home. And I think the best thing for people to figure out what's going on where is to contact what we're saying, your preferred palliative care agency. So at this point in Hawaii, palliative care is offered through agencies that also offer, as another line of business, hospice. So all of the hospice agencies also offer palliative care. So you can go onto our website and look and see what's available. I think it was Daniel that mentioned this morning, Ohana is moving forward with a pilot, which is great to hear. And we really hope that more of our health plans are going to step up to offer palliative care. This is my last slide for this part, and that is, what's happening and what's exciting. First of all, MedQuest, which is the group that offers palliative care to people who are on Medicaid. I said that wrong. MedQuest is working to develop a palliative care benefit for their beneficiaries. So this would be 5 health plans that offer care to people who are on Medicaid. And we are really hoping that we would be the first state that does this with CMS approval. This has been several years of work. Hats off to all the folks from MedQuest who are involved, as well as a number of other people who are supporting that effort. We're very proud and pleased to be involved with that. And again, we hope that we in Hawaii will be the first state to have that happen. One of the key movers and shakers of that is Hui Pohala, being led by Dr. Ray Seitz. This is a newer coalition that's working specifically to build palliative care. So folks are very welcome to get involved. I head up the awareness work group along with Hope Young, and a number of folks are here on the call today. And that was one of the groups that helped put together today's presentation. How do we raise awareness for both the public and professionals? And we're also working on workforce development. This is a huge lift, and we really want to lean into how do we get our workforce ready for this new benefit. I'm going to stop sharing the screen, and now we're going to jump into some questions. So full disclosure, Dr. Fischberg, if you could explain the difference between hospice and palliative care.
Sure, can try. It's a very common question. So hospice is, for people who have an incurable illness, and they and their doctors have come to the conclusion that they have maximized efforts to control the disease, and the focus now is on their quality of life exclusively, and generally it does require a limited prognosis, that you're in the last chapter of life, say the last 6 months of life. So hospice is not combined with other treatments like chemotherapy or hospitalization and things like that. The focus with hospice is generally trying to be as comfortable as possible every single day and spend those days at home with your family. Palliative care does not have any of those limitations. It's not exclusively for incurable disease. It doesn't prevent you from pursuing more chemotherapy or hospitalizations or whatever. Again, the goal with palliative care is living as long as you can, as well as you can with hospice. It's more that focus on living as well as you can. A happy coincidence is that when you focus on quality of life, it appears that life can be extended itself, but that's not the explicit focus of hospice. It is confusing, naturally. Hospice sort of came first, and it was the concept of hospice goes back centuries, but the modern hospice movement really sort of started in the UK in the 1970s, and then here in the US around that time. And then the hospice benefit came in 1983, and basically it developed out of a dissatisfaction, largely, I think, a lot of nurses providing care, largely for cancer patients at that time, finding that last chapter of life really miserable. Symptoms not controlled, families not supported, communication about prognosis and goals just not happening. And so the concept of hospice really trying to make that last chapter as good as it can be developed. It was so successful, and families were so much more satisfied with the care, and the care team providers also could see that people weren't suffering as much and quality of life was better and people could live that last chapter more fully, they said, gee, why do we have to save it for like the last 6 months of life? And why a lot of people in the hospital could use this kind of care too. So that kind of gave birth to the palliative care movement, to sort of take that philosophy of focusing on quality of life, symptom management, family support, emotional support, communication, talking about goals, person-centered, family-inclusive care, all of that, and saying let's move it upstream and not just limit it to that last chapter of life. And that was sort of how palliative care started in this country, and it was largely hospital-based initially, because that's where people learn that they're kind of sick, is in the hospital. And then I'd say this new chapter is moving it out into the community. So first it was moving it out of that last chapter of life and separating from hospice and saying it can be for people who are still pursuing cure, and might have years or decades, or like the case I told you at the beginning, 5 years and counting, disease-free. And now it's moving it out into the community, into people's homes or offices. And so I know that's a very long-winded answer, but do you think I touched on it there, Jeannette?
Absolutely. I hope so. And you know what? People can write to us in the chat if they didn't quite get that. So thank you, Daniel. No, I thought that was very good. And so folks know there's a short video that comes from Stanford University of the difference between hospice and palliative care. So if you go onto our website under the resources on palliative care for patients and families, you can watch that video. Anyway, this is so it's a very good question. Thanks. Okay, so I have another question here. Maybe we pitch it to this one to Sara-May to start out with. And I hope, Andrea, you see all of the love pouring out for you in the chat. It's very nice. So given the different cultural approaches to death, pain, disease management, and overlapping barriers to access in Hawaii, what have been your experience and lessons learned working with diverse communities? So maybe Sara-May, you can think about this, and certainly Daniel, if you have something to add as well.
Yeah, so I think one of the unique things that I've been able to experience with this whole process is that it's not about my story or about my opinion of something. It's really about hearing where people are at and then helping foster that environment for them. I think often we come in with an idea of how we can best serve someone, but then when we realize what they're actually going through and maybe what they're really looking for, it just comes out of listening to people and helping create the spaces that are healing for them and the opportunity for going through that journey on their terms, not necessarily just on the spoken terms of what has been handed them. And so for me, I think the diversity part is we all bring a little bit something different to the table as a team, but also that person, I think, has more to say about it than I think they realize. And so learning how to advocate for themselves and say, this is, what I would like, and this is where I want to be supported the most, and this is the term I want to be on. And I think listening and being on that journey is the most beautiful thing to face diversity and differences, maybe.
The question is around diversity, and given so many different cultures and ethnicities and people, what has been your experience and lessons learned working with diverse communities?
Mm-hmm. Yeah, sorry, apologies. It's funny because I'm at JAPSOM, and so we have lots of learners, medical students and residents and fellows, and it seems like it's so common. People, and maybe this is not what's behind the question, but it's making me reflect. So often the learners will say, what's the best way to approach a fill in the ethnicity family? And when it comes to end of life care, and I reflect that not everybody's read the textbook on how to be a good Filipino or Chinese or what have you, and that there's really the culture of that unique individual and their family that we have to have a genuine interest in, and come with a an approach of learning and humility, and just ask in your family, how are these things discussed? How is it preferred? Because I learned very early on, I came in with an assumption. It was back in New York. It was an Orthodox Jewish family. It's like, okay, maybe I should know a little bit about this. And it's like they hadn't read the textbook, and they wanted to, they're going to do something completely different. So that you can learn about what might be cultural norms and things like that, so you're not totally shocked that this is a family that's not really interested in speaking directly about bad news and things like that. So it's good to know something about cultural norms, but you can never assume. And so really just come from a place of humility and learning. And it looks like Sarah has her hand up, so I'll let the expert speak to this.
Well, it's just funny because as you're talking, I was jumping in my head like, yeah, and then there's this common thread of humanity. I think often we think people are so different, but I actually think there's this thread of humanity where there's a lot of commonality actually in it. And instead of always fixating on the differences, I think if we could learn to lean into those similarities and like that common thread, like we all think the mountain range is beautiful, or we love going to the ocean and there's something deep and beautiful about that, just finding those things that kind of fill us with hope and commonality, I think can actually be a really healing process, because sometimes we feel like, well, I'm the sick person over here and this is the person just caring for me. But then you find out, man, we both are obsessed with puppies, and then somehow that makes the conversation healthier and brighter. And so I think diversity is what we make it. And like I said before, I think listening to people and hearing where they're coming from is so important. But I think also finding those common threads is where I think my favorite is, when I find something, in commonality with someone.
Yeah, I think that's one of the joys and the blessings, as well as the challenges of being in Hawaii, is how much diversity we have and how many different approaches. But I do think at the end of the day, humans are humans. We want our loved ones to be with us. We mourn. Our heart is heavy. So I think the listening is so important. That's really good. But I will say, people all the time want some sort of standard talk. What is it like? Whatever. And that, I think, in Hawaii, we know that the potluck is not just one thing, right? Everybody brings something else to the table. And I think that for me is always one of the joys. And it's, of course, in our field, it's so interesting. How do you approach this, and listening to those individuals and their stories? So it's also deep breath. This may not be a quick conversation, but my goodness, we learn something hopefully every day. So thanks very much. Excellent question. A couple other questions. What is the difference between palliative care and regular care? That's an interesting idea. You may be prejudiced about that, Dr. Fischberg.
Yeah, you can read my face. Well, one would aspire that regular care, I guess I made a reference to primary palliative care, right? And so one would hope that those elements of palliative care, we've sort of been talking about, the person-centeredness, the family inclusiveness, the look at not just the biomedical, but the psychosocial and the spiritual, the holistic look at the person, and walking with them, and learning what's of use to them. One hopes that becomes just regular care, it's such a good question, because people would say, well, why isn't this just, when I describe palliative care, sometimes I've had this experience talking with more senior clinicians. I guess there aren't too many more senior than me now with all my white hair, but this was back in the day when there were people more senior than me. And they say, really, this was, maybe like 20 years ago. I remember talking with a senior person and said, it makes me sad to think that this now has to be a specialty. Back in the day, we just considered this good taking care of people. And I think it's part of the specialization of medicine. You don't just go see the cardiologist, you go see the left ventricle specialist now. And, it's such a specialized field of medicine, and everyone has so much knowledge that there is sort of a letting go of some of the basics of doctoring or nursing and so on, that these very basic things about caring for people. And I have to say, it's, you know, it's also part of the way our U.S. healthcare system is set up. It's, you know, it's not always so you know, friendly to the patient. So point is well taken. We would think that this should be part of standard care, and we do think that there'll never be enough palliative medicine specialists. So we do put a lot of energy, Jeannette and other people, into, you know, training, you know, the nursing students and medical students and social work students, and, you know, chaplain fellow rotating with us constantly, to incorporate these primary palliative care skills into people who are not going to be specialists, but to make it, you're absolutely right, that's the aspiration, that this just becomes regular care. I think there still will be a niche where there are some specialized situations where people are suffering more and do need still the attention of a specialist, but that would be the hope, that this is incorporated and becomes more standard of care.
It's a fabulous view. I think that would be great. And if we think back to some of those quotes from, you know, Ira Byock or other people, you know, care the way it should be. I know a number of people in doctors, nurses, social workers said, oh, once I found palliative care, this is why I went into my field. So, but yes, it sure would be great if it could keep migrating over.
And more reason for pride in Hawaii. You know, you know, John Burns is one of the minority of medical schools that mandate some education in palliative care. I was just looking at a webinar yesterday. I think it was about 15% of medical schools do that, but John Burns was one of the first in the nation to do it. So all of the medical students get education, excuse me, in the very first year. And then they do a clinical clerkship in their fourth year. And so that's trying to, even if they're going into, you know, ophthalmology, what have you, let them learn some of these primary palliative care skills.
That's great. So I want to make sure we pull Andrea in and get some of her mana'o on this. A question, and also I'm repeating it because it's also a question for me. Andrea, you've gone through this now. You accepted Daniel into your family, into the journey. We're interested in what do you find the best way it is to explain about palliative care? What is it that, like, and when you're like telling your friends, or hey, please get a palliative care you know, consult, get people involved, what do you think, what are the most important things of palliative care as we try to tell other people about it?
Well, my interpretation with personal family members who have cancer here on Maui, I refer them as my guardian angel, because that's what Dr. Fischberg was like, my guardian angel. Just emotional. Palliative care is huge. Just the emotional support that was first and foremost. A lot of people, and like we first met Dr. Fischberg, we were just, okay, this is a pain man. He's just going to give us all these narcotics and walk away, and that's it. And that's not even close to what, and excuse me now, that's not even close to what Dr. Fischberg offered. He offered emotional support to myself. And so yeah, pain palliative is more an emotional support, which is huge on your journey, huge for both patient, caregiver, wife, and even my children. Dr. Fischberg has tapped in even to my children to make sure they're okay, we're okay, and we're going to go on this journey with daddy, and we're all going to try to understand it. And yeah, ride the wave to the end. And that's what we did. And Dr. Fischberg came in clutch the last week of Lance's life, because we didn't understand he was leaving us, and we didn't know he was I'm going to die today. Literally, he woke up one morning and said he's going to die today, and that's what happened. And he had to talk, and we didn't understand. Hospice wasn't even in our home. He was at home eating musubis and Krispy Kremes, and he woke up and he said he was going to die. And I called Dr. Fischberg, and he immediately helped me get hospice supportive care into the house within hours, because my husband woke up at 6 o'clock and passed at 11:30 that day. So Dr.
Wow.
Fischberg was the one that came in and made calls, and we had hospice supportive care because we had HMSA. that came into the house to where my husband could pass it home with me and the kids within hours. So yeah, that's palliative care. It's a huge part of everybody's journey, and it's super important.
Well, thank you, Andrea. I'm sorry to make you cry, but thank you for sharing your experiences, and helping to help other people understand what palliative care is. So thank you very much. There are some more questions, so we're gonna try and see if we can get some more questions answered. One question was, are we using community health workers yet in palliative care? So I thought that was a great question. Actually, Andrea and I chatted about that yesterday because she's studying to be a community health worker. And one of the pieces of the puzzle I think that's really interesting is adding community health workers. And so if anyone else is interested in working with us, feel free to contact me directly. I've found out of some community health workers in palliative care in both Oregon and Washington. So trying to learn from some of their experiences and see about collaborating with community health workers here in Hawaii, again, to expand the team, expand those people. I think of community health workers as a bridge, again, like palliative care, between different parts and different people. So if anyone else is interested, let me know. So Maui Community College is having a free community health workers certificate program. So there you go. Good to know. And also I think all the community colleges, as well as Chaminade, are training people on being community health workers. So thanks very much. Thanks, Hallie. Nice to see you. Thanks for that. Okay. Other questions that have come to me. I think this one is a really good one. Can I keep my other doctors with palliative care? Dr. Fischberg.
Oh, is that for me?
That's for you. I'm sorry. I should have said that. Hey, Dr. Fischberg.
Heck yes. The more the merrier. Yes. No, I mean, that's a common confusion. Again, that harkens back to people confusing hospice with palliative care. And with hospice, yes, you can keep one main doctor. And then if other ones are needed, they get consulted, but you don't have, in hospice, you don't have to give up your primary care doctor or whoever's managing. You do get to keep them. But in palliative care, you keep the whole team together. And in fact, that's kind of one of the roles we play. And I think Andrea was alluding to that is, I use my telephone as a tool a lot more than my stethoscope these days, or tiger texting. Hey, Dr. Kova, this is what I heard. And, so a lot of times that's what we're doing is because there are so many specialists, and Lance was so fortunate. He had a wonderful primary care doctor, he had a wonderful radiation doctor, he had a wonderful medical oncologist. I don't want to leave anybody out, but gastroenterologist right there, the lung doctor, so many. But sometimes that game of telephone that we play as kids, the messages can get garbled, particularly when it's coming back to the family. So that's one thing I like about being in a community the size of Hawaii, where you get to know a lot of the providers, and then you can just reach out to them and say, hey, did I get this right? Is this what you're thinking? And then clarify it back to the family. So yeah, you keep your doctors in care. It's an added layer of support. I think somebody put that in the chat at the very beginning. It's not in place of anything, it's added layer.
Yep, absolutely. And, working with the team, and that care coordination, I think, is certainly one of those crucial skills that people in palliative care are building and need to build. Okay, so I have one more poll. Now is the time to think of other questions and put it in the chat, but Hope has fabulously created poll number 2. This poll has 2 parts to it. The first question: after today's presentation, how likely would you be to recommend palliative care? And the second one is, how confident are you now in the difference of understanding the differences between hospice and palliative care? Hopefully you guys can see the poll. First question, after today's presentation, how likely would you be to ask for or recommend palliative care? So vast majority of people would both ask for and recommend palliative care. So thank you, presentation team. Still, people have a little bit of question, especially one person is not sure of the difference between hospice and palliative care. So hopefully maybe we can swing back to that. So Sara-May, if somebody wants a chaplain, how does that happen?
The beauty of technology is in hospitals specifically, typically you can just call the operator and have them transfer you to the chaplain, or you can actually just mention it to your nurse and they should be able to put a request in for you, because we have in the EHR system, normally there's a request for a consult. So depending on how expedited or not you want, you can just let your nurse know and they'll make sure to get one of us out there as quick as possible, or the next time we're rounding that unit. So we try to be as accessible as possible and to make sure that everyone, if they want a chaplain, we can be there within a pretty quick amount of time. So, yeah.
Thank you. And I will say, the agencies that provide that home-based palliative care, they also usually have chaplains or someone that's willing to discuss spiritual issues. They all have social workers to talk about emotional support. So that is another thing that I would say, always you can reach out to the palliative care team wherever you are, to ask for that extra help, because as we know, palliative care, spiritual care is a crucial part of palliative care. So
yes, and that would be one of my first questions to ask if you're interested in a chaplain. So just ask whatever team you're working with, and they should either be able to direct you to it, whether it be, in home care or whether it be in the hospital care. Normally there's some version of it somewhere, or they know how to put you in contact with some kind of support like that.
Great, thank you. If someone's in a hospital, Daniel, how did they get a palliative care consult?
Ask your doctor. I'm sorry, it's like the old commercials. Because it's really important to sort of have that quarterback, whoever's supervising your care, to know absolutely everything that's going on in the case and everyone who's involved. No consultant should be coming on, without their invitation. So sometimes, nurses will request us or something like that, but we always say, no, we need an official order. It's got to come from the attending to make sure. So you can bring it up. Asking your nurse to help advocate for it is fine, but just asking the doctor is a pretty straightforward thing. If you're at one of those 83% of hospitals in the U.S. that have a palliative care.
And then if somebody wants to sign up for home-based palliative care, what's the way to, how should they do that?
Well, I'll answer that, but first I say, and if the doctor says, I don't think you're ready for palliative care, just quote Diane Meyer and say, hey, don't you know it's about need, not about prognosis? Okay. So then your question was, how do you access community? Well, I think you had that wonderful slide that so in the community, you don't have to go through all these hoops in terms of getting an order and blah, blah, blah. You just reach out, let your fingers do the walking. I think you pointed out, Jeannette, almost every palliative care hospice agency in the community is offering something regardless of your insurance. Yes, there are some insurance benefits that are more robust, but everybody's really been very creative about offering different things. So I was actually just looking on the Kōkua Mau website yesterday for it and finding so I saw there was a question about how do you get it on the Big Island. Well, it's like, what part of the Big Island? Because all three of the agencies on the Big Island, there'll be links right there, and you can look at North Hawaii, you can look at Kona, you can look at Hawaii Care Choices, and they all have different programs. And then you don't generally need a referral for those things, although I guess maybe different programs do have different criteria. They might want your primary care doctor to send some information or something, but you can certainly initiate the inquiry yourself.
Yeah, absolutely. So as we know, you can't wait around people. It's important for people to be advocates. So this last slide is, if you want to know more about what's going on, please join the Kōkua Mau mailing list. And hopefully after the session, you can go and look on our quick links, because we have pages both for, the palliative care for patients and families, and also where to find palliative care. And then we have some pages specifically for providers. So if your doctor says, oh, you don't need palliative care, like Dr. Fischberg said, but wait, you can go there, get some information. Feel free to send that. If you want, we're very happy to do, outreach to providers who may not understand about palliative care. So feel free to contact us, and we are very happy to, have some peer support and peer outreach for that. Okay, so I've been getting all sorts of nice comments in the chat. Some of them seem to are private anyway, but I hope everybody hears that this has been very well received. People are very happy, with all the questions. And again, I know folks are out there, they're advocates for loved ones, they're advocates for themselves. We hope really that today you have heard about the amazing opportunity that palliative care can bring to people with cancer as well as other illnesses. And I hope you've also heard there's a lot going on in our community to boost palliative care. So we hope that you'll come on down, get involved, and lend your voice to these efforts. So thank you very much to our speakers. Again, you'll be seeing in the chat all of these wonderful comments that people have made. And thanks to everybody for coming. If you have more questions, contact me offline. And that's it for us today. So thank you very much.